think one of the issues with pulmonary embolism is that it's not really an Bailey specialty, and quite lucky that I'm in a hospital that has respiratory, cardiology, intensive care and acute medicine, but also a thrombophilia team. So there are already interested individuals, but nobody really had shared ownership of the PE pathway. So we had an opportunity to bring those people together to try and reduce variation in practice, and we found interested people in each area, and also interventional radiology who we could train up in order to deliver particular both reporting but also therapeutic pathways as well. So the key thing is get people that are interested, keep the team relatively small, large enough that you've got enough people with expertise in the building at any one time and shared decision making, as opposed to diluting the team too much. But it's key to get all the right people involved, and it's got to be a multidisciplinary approach to these patients. Previously, the only real options we had were systemic thrombolysis and anticoagulation alone, perhaps with an IVC filter, which left this area between quite a large gap between the potential care. It gives us another option for patients who have submassive or patients who are not triggering for systemic thrombolysis, if they present in hours currently, with perhaps potential to increase the amount of availability of that in the future. It's changed the perception I have of PE as a team as well. Even patients with, say, malignancy, who perhaps you might not have considered treating relatively aggressively, you could treat them with a lower dose thrombolysis locally, and it might give them more time at home, for example, rather than time in hospital. So actually, it's got us to talk about PE and about what people's quality of life and things is like. You know, maybe if their prognosis isn't years, perhaps having more time at home, if they've had slightly more aggressive therapy, may be an option that some people would want to look into. So that's one of the key things, I think. It gives us options. PE is like the ultimate nemesis. It's really difficult to diagnose. It's the most overdiagnosed, the most underdiagnosed condition. And when we've actually picked one up, a large PE, which has got to be a physiologically large PE, not a anatomically large PE, so it's actually caused somebody to decompensate with their blood pressure and other parameters, then that's when we really need to put the steps into action. So we use a group messenger discussion group where we can discuss details, not patient identifiable details, but that's sent via secure means, and then highlighting the team and getting us ready to look at these individuals. Like I said, we share images, we share the blood results as required via secure means, and then make a decision about the care that we're going to deliver to these patients. If somebody has a massive PE, we're still systemically thrombolizing, but submassive, or if it's in daylight hours, it's a massive PE, we might consider catheter-directed thrombolysis with the ultrasound. And it's something which is new to our armoury. So because we now have it, we can now think of it. The key things are to think of PE and then think about how we're going to manage it. Not all PEs are treated the same.